Wasn't meant to be. So, okay, so without further ado, then I invite our executive director to welcome our special guest and introduce the lecture.
Greetings, everyone. Good morning, good afternoon, good evening for the die-hard evaluators who are beaming in from all around the world. I am delighted to be back in New York. It's my first day back after a very exciting four-country mission. And today in particular, I am thrilled to announce that together with Professor Christopher Murray, who you'll meet in a minute, UNFPA has signed a new agreement. We have a memorandum of understanding with the Institute for Health Metrics and Evaluation in order to help advance some of the themes that are utterly necessary for this particular year when we celebrate 25 years post-Cairo. Chris and your colleague Stephen, we are delighted to welcome you to UNFPA and also to the inaugural Cairo Plus 25 ICPD lecture, where we will be engaging with some of the foremost thinkers, scholars, scientists, NGO leaders in the world regarding how do they see the dots connect back to that 10-year-old girl who needs sexual and reproductive health education, services, and truly leadership advice in this moment. So we're very happy to have you here to participate with us, and I really thank you for making the trip from the West Coast. Now, part of the excitement has to do with what this institute, based at the University of Washington in Seattle, and my alma mater for my epidemiology master's. The Institute for Health Metrics and Evaluation was founded in 2007. It was a brand new idea at the time, and we all wondered, was this going to work? The idea being that scientists should use the output of their work to develop estimates without being constrained by anything, to let their imagination help us track data better, to be able to think about the spending and the financing equation for health better, and also to project scenarios. And we're going to hear a little bit about that excitement from Professor Murray in a minute. Chris is the chair and professor of health metric sciences and director of the Institute for Health Metrics and Evaluation, which is known as IHME. It is based at the University of Washington in Seattle, and throughout his whole career, he has focused on improving health for everyone. So solidly, as we think about the Sustainable Development Goals, the kind of evidence, the kind of evaluation, which UNFPA and our fantastic team also endeavor to contribute to, is what his life course has taken him to. And he has developed new methods, including empirical studies, very important, to strengthen health measurement, to analyze the performance of the public health and medical care systems, and to assess cost effectiveness. Are we doing the right things in the right places in the right way at the right time? Previously, Chris served in WHO. He was executive director of the Evidence and Information for Policy Cluster. And then he went on to Harvard and did many other great things on the way to founding IHME in partnership with the Bill and Melinda Gates Foundation. And we'd also like to welcome his colleague, Dr. Stephen Lim, who is professor of health metrics sciences and senior director of science and engineering at IHME. Among many, many hats, he also works on the Global Burden of Disease study, and he is the principal investigator of a global fund prospective country evaluation set. So very welcome to you also, Stephen. So look, in my remarks today, I just want to underscore why this is so important for our 3 zeros: to end unmet need for family planning, to make sure that no woman or girl dies during pregnancy and childbirth, and certainly zero gender-based violence, including harmful practices. We've always said we sit on a foundation of data, and that's how our little graphic depicts. So that element of data, high quality population data and evidence, helps us to zero in on where the needs are greatest, where people are invisible. But it also helps us to make our case. It helps us to be persuasive, as we will need to be next week in the Commission for Population and Development. We need those facts, we need those figures, but we also need to have an interpretation that gets us closer to filling the gaps, to identifying the gaps and then filling the gaps. So I'd just like to highlight that another contribution from IHME was the formulation of disability-adjusted life years. Those of you who memorized every page of our strategic plan know that we adopted this as a shorthand way of describing opportunity, risk, et cetera, et cetera. So this was a new methodology that Chris Murray and his team contributed to identifying and proposing, and that we use now. So just to close, I will say that governments all over the world are looking to us for that kind of fact-based advice, for that kind of metrics. It's one of the significant contributions that we're giving in every single country office where we work. Policy and data is part of our work. So in this 25th year since Cairo, in the 50th year of UNFPA, what I want to make sure is that the program of action emphasizes the welfare of individual women, real people in their village, in their town, in their city, in their country, so that she can have sexual and reproductive health and reproductive rights, and we contribute our share on the gender equality paradigm for SDG number 5, okay? So as we think about universal health coverage, this is the type of knowledge that's going to transform that individual woman's life. When we make the case why condoms should be in that warehouse, in the right place at the right time, after she walks the 45 minutes, the 2 hours to get to the clinic, right? And that goal is even more pertinent today than it was in the year 1994. Not only are there more women and more young people and more aging people on the face of the earth, the pushback, the political quandary of having people argue against gender inequality, against linking population and climate, right? The fleeing that we see around the world with the highest number of refugees and displaced people that we've ever had. All of this is at the heart of our efforts to establish evidence with a human rights base. So we do look forward to working closely with you, Chris, and your team. This is part of the momentum as we work on the Secretary General's reform plan to make sure that the SDGs are costed, that we can pay for them, and that we look to new and different partners in the private sector, in the communities than we have had. So vocal, visible, and valuable. That's the mantra for today. So please join me in giving a very warm welcome to Professor Chris Murray. Thank you.
Great, thank you. Well, good morning, everybody, and thank you very much for those warm words of welcome. And we are very excited to, in the future, work closely with UNFPA. And to that end, I wanted to run through a lot of different topics with the hope that it'll give you a flavor of some of the analyses that we've been trying to shepherd at IHME with a large group of collaborators. And I think some of these fit into the agenda that you have of the 3 zeros and even beyond, as we'll come to later in the presentation. So first, some insights around sexual and reproductive health that come from the Global Burden of Disease study. For those of you, by the way, we're very happy to hear that you use DALYs in the strategic framework. That's great. I think we'll probably want to write a case study of that. just for those of you who are not familiar with the details, the GBD is a long-running enterprise. It's been going for almost 25 years, or actually more than 25 years. And what we like to think of it is a systematic attempt to quantify health around the world, and to do that using all the available data. It covers every national entity, and now increasingly covers subnational countries for I think about 22 countries now, where governments have asked to take this analysis down to the first administrative level. And that includes places like China and India and Brazil, and now many others. And it also looks at both diseases and risk factors. It takes a historical view from 1990 to present and is updated every year, although this cycle we're on a slightly longer cycle of estimation, where the next installment will be next May because of our new partnership with the World Health Organization since the election of Dr. Tedros. So what I want to emphasize around the GBD that some of you may not be so familiar with is that this is a model of measurement that is not a small group of analysts looking at data sitting in Seattle. It's a model of measurement that we try to think of as the sort of we think is the new direction for measurement, which is the collaborative scientific model. We have more than 3,500 collaborators who are the co-investigators, co-publishers of the results. They are in 143 countries. We would like it to be 195 countries, but it's work in progress. But we've been pretty successful in stimulating and catalyzing collaboration to contribute to this overall enterprise across many disciplines. And, the vehicle for more intense collaboration has really been these subnational studies, where the team, for example, in India have published very extensively. It's a team that covers academia and government and research institutions, and it's now baked into, for example, the Planning Commission's strategies for state-level budgeting, as an example. So many uses that we're seeing from these subnational assessments. I go to Indonesia next week to launch with the Bappenas, the Planning Commission, and the Ministry of Health, their subnational assessment. So an example of a sort of growing momentum around local collaborator-led analyses. And I think it's really a new model for measurement, or we believe, for the future. Now, what makes the GBD a little different than other attempts? The vehicle is this collaboration, but what's a little bit different from other efforts at measurement is the focus on comparability. There are some standard problems that you all are familiar with whenever you do monitoring. Differences in definitions and coding practice, some groups with no data, 2 studies, 3 studies that give you very different answers in the same place. Lots of statistical problems that you're all familiar with about sampling error and then non-sampling error. And then the really big issue, particularly for your agenda, is groups, the poor or the discriminated against, who are often missed in administrative data systems. And so we need to explicitly take into account those groups that are excluded in the analysis. And we have imperfect, but at least standardized strategies for dealing with these problems. And I don't want to oversell the GBD because we all know it's really hard to know things that you don't know. But we try to formalize, what's the quality of each study that goes in. There's more than 108,000 different data sources that go into the GBD each cycle. And we have a toolkit that's evolved over 25 years to try to deal with a range of measurement issues. And this toolkit has been greatly facilitated by the advent of cheap computation and the practical ability to apply Bayesian statistical methods. And there's more and more with each cycle. What I think the GBD is interesting is it's a very dynamic process. We have a huge collaboration. Ideas come from around the globe. And so it's also a constantly an evolution where we try to identify critiques that people make and try to improve the methods and the data that are there to address those critiques. I'm going to give you some very high-level observations that come from the GBD. That's it for the methods, because this is a brief, sort of high-level presentation on some of the analyses that we do. But I want to give you a flavor of some of the larger insights that come from the GBD. Here's a graph of death by age from 1950. We publish all the GBD outcomes from 1990 to present. We revise those each cycle. And then for some analyses, mortality by age and sex, fertility, and a few others, we go back to 1950. These are death counts from 1950 to present at the global level, distributed by age. All the deaths in red and orange are in children. And one of the great transitions in the world has been this enormous decline in the number of deaths in children, even as the world's size of the birth cohort has gone up and now been roughly stable for the last 25 years. At the same time, the median age of death is now over 65 in the world, which is an extraordinary transition with lots and lots of ramifications, as we'll see. The big spike, of course, that you're looking at the graph is the Great Leap Forward, or the Great Famine in China, that had a huge effect on child and adult mortality. Second observation is our attempt to distill the sort of grand trends where development is a really powerful driver of general progress in health. And at the same time, there's enormous variation at any level of development, meaning there's tremendous opportunity for us as a community to have people have better outcomes even at the same level of development. So this plot shows life expectancy at birth for women for every country for every year from 1970 to present. So there's a lot of data on this plot. And on the x-axis is our measure of development. We don't like to use income per capita because there are countries that happen to have a lot of money because of oil or other reasons that aren't really that far along the development trajectory. So we measure development in a funny way, which we call it the socio-demographic index, which is 3 parts. It's income per capita, it's average years of schooling, and it's the fertility rate below age 25, because we think that's a proxy for the status of women. Because if women go to school and have opportunities, employment, essentially the birth rate before age 25, if they have those choices, is essentially 0. So think of a country like Singapore, where the total fertility rate below age 25 is about 0.1 of a child. So that we include in this general measure of development. And you can see that single measure of socio-demographic index is incredibly powerful predictor of life expectancy. But there's a 10-year variation at any level of development across countries, pointing to this incredible opportunity through policy and investment to actually make a difference, even though we know development itself is going to be this incredibly powerful driver over time. As countries go through that development transition, we've been able to document in the GBD, perhaps a little in more detail, how diseases change through the course of that development process. And so we have tried to quantify a well-known phenomenon that goes back to the 70s, called the epidemiological transition. Namely, as countries go through development, we see a more rapid decline in communicable maternal, neonatal, and nutritional deficiencies, a slower decline in NCDs, and a modest decline in injuries. And those are the 3 colors on this diagram. These are age-standardized years of life lost rates. So red is the communicable maternal neonatal causes, blue are NCDs, and green is injuries. And we put countries into quintiles of development. So they go from highest development status on the right to lowest on the left. And you can see in every quintile this big transition down in the communicable maternal and neonatal causes over time. A slowish decline in NCDs with some variation that's interesting in its own right, and then a slow decline in injuries. So that epi-transition is underway. Now, from a point of view of governments, the volume of services that countries have to face looks different, because even though the rates are going down, population growth and aging mean that you see a different mix of patients and groups that you have to take care of, and that's what's shown on this slide, which shows the sort of rise of NCDs, which is not about rates. It's not age-specific rates that are going up on NCDs. It's about numbers. And that the increase in the population and the aging of the population is larger than the decline in the rates for NCDs. And that's why you see in most quintiles, development quintiles, a steady rise in the burden related to NCDs, even if the rates are declining. Now, another observation, which I think has a lot of relevance to UNFPA, is our growing understanding and awareness that it's not just about avoiding death. It's also about functional health loss. And as we look across the world, the top left here is called a tree map. It's one of our online visual tools, which I encourage you to look at healthdata.org. Which shows a square pie chart, if you will, a tree map of the burden by cause. Blues are the NCDs, the red color is the communicable maternal and neonatal causes, and green are injuries. And the bottom right is for disability or functional health loss. And if you look carefully, it's a bit hard from the back of the room. The main point is that there is a tremendous amount of functional health loss or disability from mental health disorders, from musculoskeletal disorders, from substance abuse, from vision loss, from hearing loss, from anemia, that aren't really large causes of death. They cause some death, but if you just focus on mortality, you would focus on a different set of conditions than you get if you focus in on what makes people ill when they're alive. And I think that's one of the insights that keeps coming back from the GBD as we get more and more detail. You know, the newest addition to this is better understanding, for example, of the rise of neurological disorders, epilepsy, dementia, and others that we see, particularly as some countries are aging quite rapidly. Now, the combination of steady decline in progress, success in dealing with premature mortality, but almost no progress in dealing with mental health, substance abuse, musculoskeletal disorders, means that the rates of those conditions stay constant and the rates of premature mortality are going down. So the mix that most countries experience of burden is shifting towards the disability end of the spectrum, with profound implications for service delivery, because often some of these conditions require a lot of services, both support and care, as well as treatment. And that shift is one of the sort of profound transitions that health systems are having to tackle. In the background, when all of this is happening, we also quantify in the GBD how risk factors are changing over time. And there are really interesting patterns in the risk transition. And I'm not going to go through each of the risks, but there's a cluster of risk factors that are really poverty related. Think about poor water supply, poor sanitation, indoor air pollution that go down steadily as societies develop. There's a cluster of risks that go up and then down. Think about ambient air pollution. Whereas countries industrialize, you see a rise of ambient air pollution. And then at the highest levels of development, societies start to try to regulate and control air pollution contributions. And then there are some risks like overweight and obesity, where so far they're just going up. And we don't really have a strategy or zero success stories on bringing down population levels of overweight and obesity. So there's also this risk transition with lots of ramifications for the future. More about that in a moment. Now, one of the things that we can do more and more as we understand that powerful relationship between development and outcome is we can give a different type of benchmarking to countries, which is, of course, you want to know how are you faring on an outcome, let's say like maternal mortality. But you can also ask the question, compared to what we expect to see for your level of development, are you doing better or are you doing worse? And that gives you a different type of perspective that allows you to sort of benchmark against your development peers. And here's one example in aggregate on this map, which is the ratio of disability-adjusted life years that you observe to what you would expect for your development status. And you see a very different map than what we're used to seeing. You see places, for example, in northeast Brazil, which do relatively poorly for the rest of Brazil, but they're actually doing pretty well compared to their development status. A lot of that's due to policy strategies meant to address inequalities in Brazil. You see countries like Niger doing quite well for their development status as they've brought down child mortality, even though they have still very low levels of income and educational attainment. And you see parts of the United States that do rather poorly, because they have high burden for their development status in the corridor from, Oklahoma through to West Virginia. And lots of other interesting perspectives that these different views of benchmarking can bring to bear. Now, here's a view that's more focused on women of reproductive age. This is the leading causes of burden globally for women in 1990. And now in 2017, back in 1990, maternal disorders was number 1, now down to number 5. And you can see the sort of crossing lines as we see the rise of conditions, for example, like gynecological disorders, which were down around number 11, are now number 6 for women of reproductive age. And so I think there's a lot of transitions underway that reflect this both rising development as well as some of the shifts that we're seeing in different regions. And there's, online, you can go and look at this by country, by region, and get a perspective on it. But just to highlight how there are shifts underway that may change what you may care about. Here's another visual at the global level, teasing out some of the classic reproductive health related conditions. So this is showing the age pattern of burden around the world, showing you the gynecological disorders in dark green, showing maternal disorders in light green, breast cancer, cervical cancer in the purple shades, and sexually transmitted diseases and their consequences in children in the sort of intermediate green color. Just to highlight, there is a diversity of challenges that women in those age groups face. And of course, this pattern will look very different by region and by country. Here's taking some of those same conditions and a handful of others that have a dominant differential. For example, like dietary iron deficiency, where they're much more prevalent in women than men, showing you a selected set of countries around the world and just showing the range of variation across countries, both in the rates in women as well as the comparison for those conditions that show up in men as well as in women. So that was it on the GBD. There's a lot of resources there that you can use to get some insights. We have dynamic data visualizations. You can explore by country. You can explore by subnational units where we have permission to release those. And they're all in the tool called GBD Compare. Now, I'd like to shift to the future and talk about our scenario planning platform that we have developed over about a 3-year period and released the first installment last October. So we have produced a reference scenario or forecast for all of the mortality, causes of death, years of life lost. We're still working on DALYs that'll come out later this year. And we've forecasted them and then created alternative scenarios, a better and a worse scenario, out to 2040. And that's also all available online, all the results in a tool called GBD Foresight. And I won't go into great detail in the technical part of the model, but what's important to remember about the model is we've both demonstrated that it has good out-of-sample predictive validity, so it's a good forecasting tool, but it's a causal model where the user can change different risk factors in the GBD and other drivers. So we can ask the question, how would the future look different if we raised educational attainment faster? How would the future look different if we have faster scale up of met need? And I will show you some examples of that in a moment. Now, first on the general, what will happen in the next generation? Here's sort of at the macro global level. Top right panel is the total fertility rate. Reference is in blue. Worst scenario is in red. Better scenario is in green. Middle panel is life expectancy. Bottom right is population. And then we have an age period of population there. And just to highlight that the reference scenario continues out the historic trends that we've seen of lower fertility, somewhat slower progress in life expectancy, and there's many reasons for that we can talk about if you're interested. And then this shift in age structure where we expect to see a smaller birth cohort coming and more people at older ages because of lower mortality at older ages. Now, these are ternary plots where we try to show the epidemiological transition combined with the demographic transition in these triangular diagrams. Each triangular diagram is showing the share of burden due to the three big cause groups. NCDs at the top. So as you move towards the top, that's more NCDs. The communicable maternal, neonatal, and nutritional deficiencies are on the bottom left and injuries on the bottom right. And at the global level, there's this continued transition towards a burden profile dominated by NCDs. That's happening in all regions, but notice the bottom right for sub-Saharan Africa, where even in 2040, the majority of burden is likely still to be communicable, maternal, and neonatal causes. Everywhere else, the vast majority of burden is going to be NCDs. So, again, differentiating in these reference forecasts just how the transition may occur over time. Another aspect of the forecasting platform is we have each of the GBD risk factors as the drivers of the forecasts. So that means you can ask what if questions about each of those drivers. And on this plot, we've shown what are at the global level, and this differs very much by country, what are the biggest determinants of the difference between the better scenario and the worst scenario in terms of risks. At the top of the list are high blood pressure, obesity, high blood sugar, tobacco, alcohol, air pollution, and you can keep going down that list in terms of the scope of sort of plausible variation in the world and how those determinants are going to have a huge effect on what burden looks like in the next generation. This list looks very different for sub-Saharan Africa than it does, for example, for East Asia. And so I think at the global level, it tells you one story, but the richness of this is at the country level. Now, that's a flavor of our forecasting. We've been working on longer range scenarios. We were asked last summer to run our forecast platform out to 2100, which at first we said, why on earth would anybody want to know about forecast 2100? Yes. And it turns out that there are many groups who ask us for this. For example, the adolescent health community came to us and said, a lot of the things that we're advocating for will play out in terms of the health of adolescents over the next 50 years. So can you help us with making that case? The climate community is very interested in how climate will play out on death rates and population. And then, of course, for economic planning, there's a lot of interest in some of the demographic shifts and their long-term economic and political effects that may be coming. So we spent some time, and this is really work in progress, and it's not yet published, but we hope it will be published soon, both trying to extend our model so it still seems reasonable to make forecasts around mortality with ever widening uncertainty. That uncertainty gets very large. And then we spent a lot of time thinking about fertility because it turns out that modeling the future of fertility is really hard. And we started by modeling the total fertility rate, but the total fertility rate doesn't apply to any group of women. It's this artificial construct of totally observed age-specific fertility, and it's nothing to do with a group of women and how they may choose to shift fertility over their lifespan. So we shifted to modeling cohort-completed fertility, which takes away one of the big problems in modeling total fertility, which cohort-completed fertility doesn't really ever go down and then up, almost never. It almost just always goes down. And so we've been characterizing the relationship of cohort-completed fertility to education, met need, and we're testing right now, because we've now created a nice data set of labor force participation by age and sex, whether female labor force participation or more likely formal sector labor force participation is also a really good independent predictor of cohort-completed fertility. So we've taken that cohort-completed fertility model, we've run this out to 2100. And we are able to generate scenarios along the way because we predict for every single year. So if you're not interested in 2100 and you are interested in 2050 or 2040, we have that as well. But we can actually answer the scenario question about how much does changing education and met need change the course of future population trajectories. So our reference scenario, life expectancy in 2100, looks like this. The main takeaway here is progress everywhere, we expect on average, but still huge inequalities in 2100. And that's perhaps a reflection of past trends and what we think may continue to happen. Now, worth a digression on fertility, because we didn't know this, but it turns out that predicting fertility in the future, the UN Pop Division basically has a model that pushes everybody to a fertility rate of about 1.85 after fertility goes down and then goes up, because they're modeling the TFR. And it's pretty hard to predict the uptick. And if you look in Asia and other countries, there is no return of the total fertility rate. Our prediction of using the cohort completed fertility model of the TFR in 2100 is 1.35. The WPP prediction is about 1.85, 1.9. And every 0.1 unit of fertility difference for what we think of as the convergent fertility rate for advanced levels of development translates into a large number, namely 750 million more people in 2100. So if we're off by 0.1 on the TFR in 2100, that's an extra 750 million people at the end of the century. So our blue line here, which is the population in our reference scenario, is a global population in 2100 of 8 billion. UNWPD's number is 11 or over 11 billion. So there's a 3 billion person difference. And that is exclusively due to the difference of whether or not societies go down and then bounce back up to 1.85, which is what UNPD says, or as in our models, fertility just goes down in terms of cohort completed fertility and sort of tends to converge towards about 1.35. Huge difference for the people who care about that on climate and others. And we start to see divergence soon, even around about 2050. We have a very different population trajectory for sub-Saharan Africa, a much lower population than what the UN has, because we see education having an effect eventually in Africa on reducing fertility faster than what their models say. Here it is for sub-Saharan Africa. We have a population in 2100 around about 2.5 or 2.7 billion, as opposed to about 4 billion from WPP's latest round of estimates. Now, this gets really interesting when we try to link what we're doing and to economic modeling. So here's something that emerges from looking at these numbers, which is the number, not the rate, the number of working aged adults, age 20 to 64. China has been benefiting from a 1.3% increase in the number of working aged adults for the last 30 years. And that's been part of their growth rate. I'll show it in a moment. Starting now, they actually start to decline at 1.3% per year. And this is a consequence of the one-child policy. They are doing attempts now to bring the fertility rate up, but that'll be a long time if it works at all. And so they are the gray line here with a very large decline, which the State Council in China is very aware of, and it's a very high priority challenge. The red is India, which will peak around about 2045. And you can see Nigeria coming up to have the same number of working aged adults at the end of the century as China and India. And interestingly, because so far of relatively permissive and inclusive migration policy, the U.S. has sustained its population. And if that migration continues, the U.S. would still have in the yellow line quite a large number of working-aged adults and not experience the declines that China and India are likely to see. Now, that's asked the question, can we link this all together? I think you said connect the dots. So we've been trying to do that. Lots of people ask us to do this. We were asked to do this for the Goalkeepers report from Bill and Melinda Gates. So we do quite a lot of the numbers and the modeling that goes into Goalkeepers. And so the vehicle to try to connect up what happens to health and reproductive health to economic outcomes is both the working age population, but also around human capital. Basically, the education, functional health status, and learning that the workforce experience, and that makes up this notion that goes back to Adam Smith of human capital. And we published last September our first effort at measuring human capital. We constructed a measure that was based on years of schooling, based on functional health status for a series of conditions with a known link through microeconomic studies to economic productivity, and looked at all the learning or testing data and constructed an index of human capital from that. And the key thing here is this graph, which is really a correlation, because it's very hard to prove causation, between how much countries invest in their people through human capital formation and growth rates. So the far right is the quartile of countries that had the most progress in their human capital, and they have about a 1 percentage point higher rate of progress in terms of GDP growth on average than those that invested much less. So it's a credible or a plausible connection between human capital formation and the prospects for the future. Now, some of this is related to reproductive health, both in terms of the effects of fertility on the size of the workforce, but also if you look at a number of those functional health status conditions that are in human capital, they are related to reproductive health, as well as, of course, the powerful connections between education and reproductive health services in both directions. So let me end with this notion of what is, I think, going to be one of the biggest policy debates of the next generation, which is for all those countries facing a declining workforce, which are going to be many, there is going to be intense policy debate about what they do about it. And that policy debate can be constructive, invest in human capital, raise productivity that way, or it could actually be pretty counterproductive, because if you go back to the 1930s, when fertility rates were low, already below replacement in Europe, there was the rise of rather unfortunate policies around trying to restrict reproductive rights for women, encourage them or force them to have more children, or set up an environment where that's going to be more likely to happen. And of course, that's always a real risk as countries start to think about what they can do to deal with the decline in the workforce. And so I think there's really timely to be thinking past the immediate priorities to how do you make sure that this set of challenges is an opportunity and not something that actually is counterproductive for both women's rights and for reproductive health. And so I think we hope that this sort of quantitative scenario planning and building can be a tool that you and many others that you partner with can use to sort of stimulate and catalyze that discussion. I've gone on too long, but I had a lot we wanted to say. Thanks.
I stay.
Beautiful. Really.
Thank you very much, Professor Murray, for this lecture. I'm sure my colleagues here will have many questions. I don't know, Jacqueline, how many country offices are connected now?
Yeah. Yes, we have about 75 offices connected. And if anybody online has a question, please send it in through Voices, and we'll put it to Professor Murray.
Thank you. Before I give this floor to colleagues. I can see faces here bubbling with many questions. I just want to provide you some reflections. Next week, on Monday, we'll be presenting to the Commission on Population Development the trend analysis we did on ICPD indicators from 1994 to 2018 to see how the world has performed in relation to some of these indicators. And it's quite shocking to see how the world is becoming more and more diversified, from inequality to life expectancy to urbanization, but also to health outcomes, to fertility, to harmful practices. And the population growth is showing that even the success that we might expect for family planning prevalence or child marriage prevention is not showing because the population continue to grow. From your presentation, I see that the future scenario, health scenario, and the long range speak directly to us. But when you conclude on the human capital, our disappointment was that when the human capital index came out, most of the key indicators that were taken gave more importance to nutrition, to education and learning skills, but the fertility of adolescents that you mentioned didn't come out as a key major development indicator to take into account. So for UNFPA, reflecting on the future of the ICPD, reflecting on how SRHR is going to fit into the whole political debate on universal health coverage, that is like we have missed an opportunity. So my question here is, how do you assist us to catch that missed opportunity so that we make sure that SRHR is part of the universal health coverage conversation and is part of the human capital understanding by policymakers? So this is just a reflection on what you have presented, but I know that Natalia wants also to follow up before we can open up the floor.
Thank you, Benoit. And thank you so much, Chris. I think a lot of this was probably news to many of us, some of it to me, certainly. I think the clarity of the graphics are like a marvel of modern communication. It's really hard to pack so much meaningfully into the slides as you and your team have done. And I think on the substantive areas, there's a lot for us to think about. Here in headquarters, in every country office, we're really striving to be able to show that we're checking the box on certain results. So we're really looking for the metric side to be able to guide us. And I think your comments on comparability is something that we struggle with every time we sit down to analyze data for a report. So thank you so much. Thanks to the team for the skill that goes into this. And I also like the fact that you are reaching to, I would say, non-traditional ways of looking at the picture. I think that's something that we can gain a lot from in UNFPA. You know, last week I was talking to pediatricians, typically not our quote unquote audience, but at the same time, you know, the neonatal advantage is in their hands. And that pregnant woman's fate is very much a family cycle issue. People would like to have a live newborn, and certainly we want to avoid unsafe abortion, et cetera. So this is really a very good example of how we can apply data to be able to try to reach for the forecasting type of scenarios that you're. This is very elegant, very beautiful. For me, I have two things, and I'm sure there are many other questions as well. One is, how does your team look at describing an event that's prevented? You know, thinking about Stephen Lim's work as well. For the United Nations, we find it difficult to take credit for that famine that does not happen, for that humanitarian disaster that we avoid. And we would like to be able to say, because of the hardworking UNFPA people in 155 countries, we avoided dramatic disasters of, childbirth and pregnancy. This is something that we have entrusted to Marco on our evaluation team to look at, but it's not that easy to do. And I just wanted to reinforce that this socio-demographic index uses total fertility rate as one of the three criteria. And we have to always be very anxious about making sure that choice appears in that depiction. There may be women in a developed country scenario who are only having 1.3 or 1 point whatever children, because what are they going to do when they're at work and no one is home to mind the baby, and et cetera, aging parents. So this is very important discussion for us, and I couldn't be more pleased with the discussion. Thank you.
Thank you, Natalia. Chris, you want to reflect on this while colleagues are preparing, or we get more questions?
Yeah, let's get it all out there.
Okay.
There were hands.
Yeah. Thanks. Okay. Thanks.
Okay, go ahead, Marike.
Tell us who you are.
I am Maria Bellerano, and I work here in the gender branch. Thank you so much for a thrilling presentation. My question may be a little bit odd at this point, but I would like to know whether you have considered antimicrobial resistance. I didn't see antimicrobial resistance as one of the factors that you mentioned, risk factors. And according to the Chris O'Neill study, most people is going to die of TB, and even if they don't die of TB, probably they are going to consume all the budget for TB because we have resistant tuberculosis. And what about gonorrhea and all other infections? In Sweden, for example, they don't operate. The decrease of operation for hip replacement is visible now because of resistant infections.
Thank you. Rachel?
Thanks so much, Chris. Really fabulous. I agree with my goodness. The graphics are so beautiful in terms of communications. Amazing. I have two questions. The first one is fairly simple, possibly. I know Eileen Crimmins and others are worrying that obesity right now may, in fact, mean that this young generation, in fact, doesn't appreciate the life expectancy that has already been achieved by the older generation. I wondered where you are on that, if you think that there's any indeed risk of life expectancy indeed actually regressing given the obesity epidemic. My other one is something already that the ED has alluded to, and that is if you're putting labor force participation into the models and looking at its impact on future fertility, we are seeing in a number of countries and some good analyses that it really depends on so much of how the employment structure itself enables women to combine work and family. And so I just wonder if you're looking right now at labor force participation, I think just contrasting like Sweden versus Japan, where some countries seem to in fact enable women to meet a fertility desire that frankly seems to be close to 2. I mean, there's this convergence that the global ideal of family size is 2. So Sweden seems to enable that in their workforce, in their structure, Japan not. So how are you working with that kind of country by country variation and the way that the labor force enables women to have children?
Thank you, Rachel. We take Rebecca and Farah. And
Jenna, sorry. Jenny was next. Can I ask everybody to identify themselves before you ask your question?
Let us know when you want to answer.
Okay. Thank you, Professor Mara. That was incredibly interesting. I just wanted to make one comment that in our India country office, we've been doing a lot of work on looking at the demographic dividend and opportunities on a state-by-state basis. And I've actually been working with the government to categorize Indian states into 3 categories of where they need to be investing in young people, where already the demographic dividend of young people has moved, and the investment in older generations, older people, is really essential. So I'm very interested to hear the work that you've been doing and how we can start to partner in with that. Thank you.
Rebecca, then Farah. After that, we.
Okay, thank you. And my name is Rebecca Reichman-Tavares, and I'm working here as a consultant with the Every Woman, Every Child initiative of the Secretary General. My question is also related to labor force participation, and you commented about the long-term or in some cases shorter-term decline in human capital and what the policy implications might be in the future, what we've seen in the past in terms of reproductive policies or reproduction policies, and should we be concerned about the future? I'm wondering, is there any research that links, the human capital analysis is the supply side, but on the demand side, we see such dramatic changes, especially with AI, in the need for human capital. And do we have any research on the declining need for human capital as it interfaces with the decline in fertility and population with development?
Thank you. Farah?
Yeah.
Then
No, thank you very much. I'm Farah and I work in the Policy and Strategy Division here in HQ. So my reflection is related to violence against women and the effects or the burden of violence for health, for mental health and injuries. The different categories that you've put. It's actually across the spectrum. And so in these cases, particularly because as you're aware, it's like one of our transformative results. So we are seeing the burden across, like mingled with the mental health in the injuries, but not, coming out. So how we can position using this analysis in that? Thank you.
Thank you. We are going to allow Professor Murray to get some answers. Just Jacqueline, do we have questions online?
Not yet.
Not yet. Okay, thank you, Prof.
Okay, great. Those wonderful set of comments and questions. First, to the comment about the emphasis on nutritional status in human capital, the index. Just to flag, there are two human capital indices, ours and the World Bank's. The World Bank's measure only has stunting in it, right? And it started out as one measure. Jim Kim asked us to create a human capital index, and at some point we diverged along the way. And our measure, again, imperfect, but still we have 8 different things that we include on the functional health status side. And these are driven by the literature about where there's a proven relationship. For example, anemia is in there. Many infectious diseases are present. So it's less dependent on one measure, stunting. I think the right answer to your question, however, is in formulating the right type of scenarios. Like, what is an alternative scenario where there is better reproductive health service delivery, and how will that play out? And I think that's the type of, essentially bespoke scenario building that would make sense for your agenda. On your question on quantifying things that were prevented, it's interesting because you can. We track coverage, as an example, we track coverage of vaccination. And you can answer the what if question if we accelerate the coverage of vaccination or rapidly increase it. But given the machinery, it's just as easy for us to say, well, what if vaccination coverage dropped precipitously? Or if you went back in time, it's also feasible to ask that question. So if there's some quantification of the pathway through which the effect is happening, then I think those sort of alternative scenarios, even past scenarios, can be constructed. On the question, I was smiling about AMR because we have Sally Davies, who's on our board at the Institute for Health Metrics and Evaluation, who's the Chief Medical Officer for the UK, international champion for AMR, was critical in steering us towards adding a 5-year project to incorporate AMR into the burden of disease work. And that's ongoing. That turns out to be quite hard because we have a lot of information from labs about pathogens that test to be resistant. but there's very little information that links that to individual clinical diagnoses. So we know that of all the urine tested in a lab in Zimbabwe, what's the MICs or the resistance pattern, but we can't link that to, who was really sick and who died, or that linkage is in many fewer data sets. But we're doing what you can, which is the ethos of the GBD, and we will have results, but I think that's probably another year. I think what we will find from that is that there are some conditions for which resistance rates are going up steadily, but many, they're pretty stable, the resistance rates. So we'll see where it falls out. But it's been quite a large undertaking, and it's something we're doing jointly with the University of Oxford, where we actually have a joint unit at Oxford that's focused on AMR. Obesity and life expectancy. So what I showed you for the forecast include our forecast of obesity, right? So we've taken the meta-analyses of all the relative risks. We have projected out obesity rising pretty steadily and included that into the forecast. So we don't see a decline in the reference scenario. We see a decline in the worst scenario in many high-income countries. But in the reference scenario, we don't. But you see a slowdown. So the pace of progress in middle and upper income countries is slower, and a good part of that is obesity. But the idea that it'll overwhelm all the other trends we don't see in our framework. If you isolated just the effect of obesity, then of course you would see a negative decrement on life expectancy. So that's certainly true. Labor force participation, really interesting question. Is the Northern European high level of fertility related to their strong support for women in the workforce, and the low level in a place like Singapore not? If you talk to the people in Singapore, they'd say they give a lot of supports because they're very worried about low fertility, and they haven't seen any effect of those. And so there's the big question is it what's the drivers here? How much of it is preferences of women? How much of it is the labor? And I think there's so little actual research on what are the levels of fertility that societies are in ideal circumstances would go to. But if we're missing something and we can build that in, we'd love to, because we've been looking for things we can test in the data on fertility. And of course, the difference between a Taiwan or a Singapore and what we see in Sweden is pretty marked in terms of the levels. Demographic dividend in India. We have our Indian collaborators have a plan to use the state level forecasts that will be coming out for later this year, and they plan to launch them with the government. And it would be an easy thing to connect up because they include, at least out to 2040, the changes in the workforce and the demographic dividend. AI, yes. Do we need all those people? I'm a big fan of Yuval Noah Harari's books and *Sapiens* and *Homo Deus* and 21 Questions for the 21st Century. We have not explicitly modeled the rise of AI in our models. We've thought about it. It's pretty hard to think about how we would do that. They're implicit a little bit. What we have done is we've because we forecast GDP, and by the way, we've done tests to see whether we're better at it than the IMF, and we are at least as good as and usually better than the IMF at forecasting GDP. But that aside, if you think about the size of the workforce and then output per worker, grows tremendously, and that includes all the technical innovation. And, AI may just be in that train of, if you think of a country like China, output per worker has been growing at 7.5 percentage points over the last 25 years. And so, that's sort of embedded in there, but there could be this sort of discontinuity of change, very hard to capture in the modeling. And I am a terrible writer. Oh yeah, right, GBVs. Thank you. Last question there. We have in many cases, because it's not just GBV that's spread across different outcomes. We do these sort of custom aggregation of outcomes. Example, the mental health collaborators in the GBD have put together, depression and the fraction of suicide that's related to depression and drug use that's related to depression and mental health to get the sort of more comprehensive view. And we could also think about doing that and trying to extract the different indicators. If there is, the missing part there is the systematic review to say what's either the fraction or the relative risk of these outcomes related to gender-based violence. We do estimate intimate partner violence already in the GBD and have done those systematic reviews. And we are trying to extend that to non-intimate partner violence. And that's sort of work in progress. So that would be the mechanism. Just hasn't gotten in, that work just hasn't been done yet to do the systematic reviews on the relative risks.
Thank you very much. We go for a second round.
Sure. Let's start off with a question from the field. We have a question from our colleague Karen Dadurian in Syria now, and he says, thanks for the excellent presentation. 2 factors, climate change and migration, likely have a significant impact on fertility, life expectancy, global disease burden. How do you factor those into your modeling?
Thank you. So we take Annika.
Another one?
Thank you. Annika Knutsson. I'm the chief of the Sexual Reproductive Health branch here at headquarters. I have 3 quick ones. One is on how the fact that we now see that more direct causes of maternal mortality is rising, which is the communicable diseases part, and where does that go in terms of how you measure communicable diseases and the maternal mortality piece. My other reflection is investment in education is part of the human capital. Could we say something on particular parts of education? So what I'm asking is, investing in CSE, comprehensive sexuality education, is extremely important for our issues and for the disease burden related to many of the areas you've been talking about. So would there be an opportunity to look at that in particular? It's so much more than sexuality education. It's really about life skills. And then my third reflection is Margaret Crook's commission on quality health systems that was published last year talks about the devastating fact that more people die from poor healthcare quality in facilities rather than those that do not seek care. And how, in your view of measuring, does that reflect on the disease burden and on the mortality burden that we see?
Thank you, Annika. More questions? Jacqueline, how are we doing in terms of time?
We have 15 minutes, and I have a couple of more questions that are coming in. Let me read them here. Shall I do that? Okay. Another question came in from another colleague in Syria. Working in a crisis country like Syria, is there any global projection for daily and SDI given the limited data we have?
Sorry, could you repeat the question?
Yes.
I get extra points for staying up for this.
Right. So our colleagues in Syria working in a crisis country like Syria, is there any global projection for daily, DALY, and SDI? Given the limited data we have?
It's interesting. I wonder if they meant country versus global.
Yeah, I think so.
I'll go on to the next question. The question is, I would be interested to hear more about the excluded groups mentioned in the presentation of the GBD, particularly as it relates to indigenous peoples. Because we are not to leave anybody behind, how do we go about identifying them, knowing how many they are, and collect data since governments don't recognize them, and there is often a major lack of trust between these populations?
You could also talk about disability,
Yeah,
which is
yeah.
a focus group.
Thank you. In the room?
Okay, we're good.
We're good? Okay.
Yes. Thank you very much. Again, I joined the others to say this was very wonderful. The way it was shown, the graphics are excellent. We envy you. You mentioned that your model has this projection of 1.4. Yeah. As opposed to one which predicts an increase to 1.8 or something. Basically, just a replacement. And also I look at Africa, for example, and you showed Nigeria kind of catching up with the big boys or the big girls. So my question is, to what extent are you factoring in actually a variable we used to really use a lot, ideal family size, and how that would affect the future projections for Africa?
Thank you. I think that is Sarah. Okay, Sarah.
Hi. So just if you could expand a bit more on the gender dimensions of the DELI, because I know some studies were conducted after the Global Burden of Disease study was released, looking more carefully at how women are, what's the burden of disease for women and how it is changing over time, and what are the things you could share with us. Thank you.
Thank you.
Great. Thank you. Again, another great set of questions. Climate change and migration, I should have mentioned it. I keep remembering to add it because every time we present about forecasts. We don't have in what I published in October, climate change. We've had a ongoing effort. Steve Lim has been leading quite a bit of this to try to first quantify the relationship between temperature and outcome to get the direct effects of climate change, and that will be added to the GBD in the next cycle. Super interesting topic in its own right. But climate, we will be adding also the pathway through sea level rise, extreme weather events, and then potentially the biggest of them all, climate change through reduced agricultural output in rural areas and therefore rising rural poverty in some locations. We've been trying to start to explore on the scenario side on the migration models, because right now we have not done that much work on migration. We recognize that the UNPD migration assumptions aren't sensitive to policy and they don't take into account things like climate and conflict. So we're trying to see if we can do that, but that's probably a longer effort. So I think we'll be able to capture climate sooner rather than those sort of direct migration effects. The three questions, quickly on those, the direct causes of maternal mortality. You know, the challenge on the coding of maternal deaths is very great, right? The more we dig into the details, it's really hard to be sure that there isn't quite substantial coding practice change. The other thing that also factors into that is late maternal deaths. You know, the UN definition excludes late maternal deaths, but we see more of those in countries, and we try to capture those. So I don't know the answer to that. Certainly for HIV, obviously, but for other causes, is it a real phenomenon, or is it a shifting coding practice that we're not super clear about? For teasing apart education, like the contribution of CSE, I think that will require some sort of review of the evidence that's out there, because I don't know the answer to that. We have this absolutely overwhelming evidence about education as a driver, measured as years of schooling. For the economic aspects, adding in the testing part makes it a better predictor. But for isolating in on important components of the content of education is, I guess, the next agenda in a sense. But we haven't done any of that work. I think it would be interesting to do that. And then the Crook Commission. first of all, we're very happy that the Commission and Margaret Cook used the GBD as the main statistical basis for trying to look at quality. And, we have, in our collaboration with WHO, have been very enthusiastic that Dr. Tedros wants UHC measurement to include the quality of what's delivered and not just access. And so I think that shift is really coming broadly. And as we speak, there's a member state consultation in Geneva about how to transform the measurement of UHC, focused on this notion of effective coverage. So I think that agenda is really becoming front and center. DALYs and SDI predictions, yes, we have those for every country. I was emphasizing global, but we have forecasts of SDI and DALYs, with all the weaknesses given the data. You can access them online if you just Google GBD Foresight. They're freely available already for the years of life lost outcomes, not the non-fatal yet. That'll come later this year. Excluded groups, super hard challenge. I think the main thing there is to try to identify where we suspect there's groups that are excluded, and that varies by country, and then see if there's ways to try to correct the data. So that's a very country context specific effort at trying to figure out what partial data are available. Some groups, so far, no real nomadic groups as an example, where I don't think there's any real effort, successful effort at incorporating so far some groups. On disability, just generally, an awful lot of the effort around the GBD is trying to characterize disease prevalence, and then the severity as evaluated by the population of having different health states, and then trying to figure out what fraction of the population that has a problem are in different states of severity. And I didn't say a lot about that, but the disability component is a really important part of what we do in the GBD. I think there's a lot of untapped detail that could be used if you're interested in that. A question on ideal family size. We have not explicitly incorporated that. I think not us, but some other people, when they have tested whether independent of things like educational attainment, you get any extra predictive power from the data on ideal family size. I don't think it's added to the predictive power, but that hasn't been in. Maybe we got cut off. Talking too much. Somebody told me to stop. But I don't think that's been in this context of very low fertility. So I think that would be certainly worth exploring. And then the last question on gender dimensions. Everything in the GBD is by age and by sex. And, sex is not gender, but still, figuring out the rates in females is a step in that direction. And so there's a tremendous amount of detail. One of the emphasis in the GBD 2017 publications, one of the themes that ran through the papers this cycle was sex differences in the rates. And so they teased out some interesting ones in that piece. But it's a resource that can be mined for getting insights on that pretty extensively.
Thanks so much, Chris. I just wanted to briefly add before Benoit and Jacqueline close us out that Professor Chris has also put the neonatal issues on the table. This is something that ANECA has very much in mind, that we are co-responsible with UNICEF for that neonatal outcome. And I think there's a lot more that we can think up and do better to improve on the neonatal side of the equation. And I just, again, wanted to thank Stephen for coming out, your team back in Seattle, and also our entire team here in pulling this together and in advancing our memorandum of understanding. We can really learn a lot from each other, and I think we have the insight and the tentacles into each of our 155 countries, that if we can show to our board, to each other, and to the world that we're making progress on the 10-year-old girls' issues, is really going to be of great benefit as we think about the 11 years left till 2030. Thanks. Thank you, Benoit.
Thank you, Natalia. Actually, Chris, this is not your first visit to headquarters. When we met last year at the spring meeting, we had several calls, and then you visited us on the 4th floor. We had a conversation on the data, the projections, and all the hypotheses, underlying hypotheses. I think that's the foundation. And as UNAPA, we are very much involved in a good relationship with national statistical offices. And the collaboration that you started with, that is, unless we have standardized data, it will be very difficult to bring credibility on the work you are doing. We are looking forward to look at how we are going to collaborate in the future health scenario, because that is where, as you responded, we can build scenarios on the changing behavior that determine sexual and reproductive health outcome, which determine the fertility and determine the future of populations. I can see that most of us, many of us, are going to apply for sabbatical leave to come in Seattle, to come to Seattle. But bottom line, we are looking forward on quickly operationalize the memorandum of understanding, how we are going to add when to get to zero. I've seen some good studies that we have done on infant mortality, preventing infant mortality, which we can apply on getting to zero in our three transformative goals, and how we add the cost of non-acting on those. So that is where we are. We are also very closely monitoring the index on human capital, on which we are working on a universal health coverage with WHO, and we are part of that group as part of the expert group on SDGs. And we are looking forward to very close, effective, and friendly collaboration. Thank you again for making the journey. It is only Monday morning, and then that is a good start of the week, and a good lead to Nairobi, and a good lead to the CPD, and hopefully we continue pushing that data is not only a tool, it is a real accelerator to development. Thank you very much.
Thank you.